Healing Hands Health Society presents Dental Webinar Series. We have planned a series dental webinars to keep you abreast of current practice. This series on prosthodontics will be via Zoom, Facebook Live. Presenters are drawn from dental schools in the USA, private practitioners from around the world. To register for future webinars, visit www.hhands.org/dental-training. For future inquiries, contact Facilitator.
Dr. Eisa attained his dental degree from the Riyadh University in Saudi Arabia. He worked as a demonstrator and a teaching assistant in prosthodontics at the prosthodontic department in his university for 3 years. Currently, his main areas are orofacial pain, prosthodontics, and dental sleep medicine. He completed a one-year prosthodontics fellowship in 2017 at the University of Michigan. Dr. Eisa is an orofacial pain resident and a teaching assistant at the University of Kentucky College of Dentistry. Dr. Eisa has wonderful recommendations. Dr. Saglik speaks highly of you. I'm like, wow, if Dr. Saglik speaks highly of you, then I need Dr. Eisa on Dental Webinar Series. Welcome to our series today.
Thank you for having me. I appreciate your invite to have me here.
No problem. I'm going to stop sharing my screen so you can take it away.
Okay.
Dr.
Okay, so can you see this?
Yes, clear.
Okay. All right, so what I'm going to talk about today is oral appliances for the management of obstructive sleep apnea. So my name is Elfatih Eisa. I'm a third year resident at the Orofacial Pain Center at the University of Kentucky. I am originally from Sudan, but I studied in Saudi Arabia. And here in our program, in the orofacial pain program, we do treat patients with a lot of different diseases, and we look into things like TMD, neuropathic pains, and one of the things that we look into is or treat is obstructive sleep apnea. So my talk today is the management of obstructive sleep apnea with the use of oral appliances. And before I go on, I just want to mention that most of my talk today is heavily based from a paper that I referenced over here. It's from Hamouda et al. I thought this is a very good paper for anyone who wants to know a little bit more about the management of obstructive sleep apnea with oral appliances. I think it's a very good read and recommend it to anyone to take a look at it. Okay, so before I start, I want to declare I have no conflict of interest, and any material or any device that I mentioned today is just mostly those devices, we use them in our clinic. So if you have any questions, you just please feel to ask me. So obstructive sleep apnea is becomingly more prevalent, like sleep disorder. And we do see it more kind of commonly nowadays. It is characterized by either recurrent episodes of partial or complete obstruction of the upper airway. If it's partial obstruction, that's what we call hypopnea. And if it's complete obstruction, that's what we call apneas. And untreated OSA is associated with multiple adverse health outcomes. Some of them, it could be stroke, hypertension, coronary heart disease, arterial fibrillation, decreased quality of life, and increased mortality. And if you kind of like think about it, this might be the only disease as dentists, if we treat it, it could be kind of like life-threatening. So yeah. And if we want to classify the severity of the disease, we classify it according to the apnea-hypopnea index. That's what we call AHI. So if they have an AHI less than 5, this is considered normal. If it's between 5 and 15, more than 5 and less than 15 is considered mild, and if it's between 15 and 30, it's considered moderate, and if it's more than 30, it's considered severe. And for the management of obstructive sleep apnea, we can classify it into four categories. So the first one is lifestyle modification. That would be diet and losing weight. The other thing is upper airway surgeries, and there are many, many different surgeries that can be done. And the next one is CPAP, CPAP therapy. So CPAP is what is called like continuous positive airway pressure. I'm sure most of you saw it. It's this mask that the patients wear when they go to sleep, and it just push air into the lungs. And the last one here is the oral appliance therapy, and that's what we're going to focus on mainly today. There's one more thing that I wanted to mention is there is this new device called hypoglossal nerve stimulation. And what we know is the action of the hypoglossal nerve, it protrudes the tongue outside if it's stimulated. So this device, if you can see here, it is surgically inserted and it is put in that kind of like chest area. So if the patient, they stop breathing, what happens is the device sends impulses to the nerve, and that will stimulate the nerve, making the nerve contract, and then when it contracts, it goes outside, or it kind of protrude a little bit outside of the mouth, and that's it. It'll clear more airway for the patient to breathe. So the classification of oral appliances, they can be classified into two: either those devices that protrude the tongue, or those that protrude the mandible forward. The ones that protrude the tongue is called tongue stabilizing devices, or tongue retaining devices. And the ones that protrude the mandible forward, they are called mandibular advancement devices, mandibular advancement splints, or mandibular repositioning appliances. So the American Academy of Sleep Medicine latest guideline, they recommended the use of oral appliances for those patients who, or the chief complaint is just snoring, who don't have any like obstructive sleep apnea, or for those who have obstructive sleep apnea, but they cannot tolerate the use of CPAP, or they just refuse to use it because for some of them they might feel claustrophobic. I mean, imagine having this kind of like mask trapping like your entire head. So for some people, that might be a little bit difficult for them to use. And the latest guideline does not specify a particular disease severity for the oral appliances. It used to be in the past that they mentioned these oral appliances can only be used for mild or moderate cases, but nowadays they do not specify like a particular severity, and that is just something that tells you more that about the efficacy of these appliances. So the types of oral appliance and indications for use, there are many devices, and they can be either custom made or prefabricated. They can be that's what we call monoblock, or they can be like two pieces. That's what we call dual block. They can be either like fixed in just one certain position, and some of them can be titratable, that you can kind of like move it forward and backwards. They can be fabricated from hard or soft materials. Currently in the market, there are more than 100 different types of designs that you can see, and we wouldn't say per se that there is one better than the other one. So when we talk about the tongue stabilization devices, they can also be custom or prefabricated, but they are, in general, they're a little bit less comfortable when you compare them to the mandibular or oral appliances. I mean, when you look at it, it might look a little bit silly, but it does work. So although it might look kind of like that way. It is still a viable option for any patient who are completely edentulous or they are partially edentulous. And the custom-made titratable dual block or appliances are in general superior to the monoblock and the non-titratable appliances. And within the custom-made dual block category of appliances, these different devices, they seem to have a comparable efficacy. So none of them is, we can't say per se that there's one that works better than the other one. For patients who have bruxism, there's an alternative that can be used is we can reinforce these appliances. If you look closely here, you can see that there's kind of like a metal mesh inside of it. So you can reinforce these appliances and hopefully these will increase the longevity of the appliances. For edentulous patients, the treatment options might be a little bit limited. There are some talks that they say tooth loss seems to increase the upper airway obstruction during sleep. But there is also other evidence that say that the use of dentures during sleep reduces the obstructive sleep apnea. So Medate have reported that the use of dentures increase the apnea-hypopnea of the patients. There are alternative options for edentulous patients, including implant-retained mandibular occlusal appliances and surgical treatment. Hakima et al. Reported the use of implant-retained mandibular oral appliance in 6 edentulous patients. And there is another study by De Carlos who reported that the use of ortho implants, those micro implants, improve the HI in patients with mild OSA who are fully edentulous. So it'll look kind of something like that. But just keep in mind that most of these studies, they are just case reports and we don't have anything kind of like in a big magnitude. So for oral appliances, we need to have healthy dentition and definitely also we need to have a healthy periodontal tissue. And they have to be without caries and no periodontal disease. And one of the also important things that we need to have is for the patient to have 8 to 10 healthy teeth. And at least that should be in the mandibular arch. For the maxillary arch, we can get away with having them be edentulous, but we need to have 8 to 10 teeth in the mandible. There is this design by a company called Somnomed. It can work for a fully dentulous upper, but they need to have some teeth in the lower. And one other important thing is they need to have at least 5 millimeters protrusive range. If it's less than that, the treatment might not be very effective. And when we talk about TMD, the presence of TMD is not a contraindication for the use of oral appliances. There is a study by Perez et al. That looked into TMD, and you can see at the beginning, I think they were around like 18%, and by the end of it, they were around like 8% TMD. So actually in that study, we saw the TMD symptoms actually decreased. So it's definitely not a contraindication. So when it comes to the titration and the advancements of the appliance, we need to have kind of like an interdisciplinary team approach. So this will first start by having a physician. This physician is the one who will make the diagnosis of the obstructive sleep apnea. And then after that, they will, it should be followed by a consultation and or examination by a qualified dentist. And I cannot stress this enough. We as dentists were not trained to make the diagnosis of obstructive sleep apnea. Not every patient comes with snoring or any sleeping disorder. It means that they have obstructive sleep apnea. There are over, I believe, 80 sleep disorders. So we need to make sure that these patients are seen first and diagnosed by a physician. And the way that the physician will do it is by making doing a sleep study and counting their apnea, hypopnea while they're asleep. We as dentists, we can use some instruments. One of them is called stop bang. That one will help us kind of, or it'll give us kind of like an idea. Maybe this patient is in high risk for having this obstructive sleep apnea, but we are not supposed to diagnose these patients. So after you have done the consultation and you saw the patient and did your oral examination and you have the results of the sleep study, what you're going to do, you're going to take an impression. This impression, you can take it with an alginate impression or with any kind of material. And you can even do it digitally if you want. And the next thing that you're going to do is you're going to take the bite registration. You're going to take it with something called George gauge. And that George gauge, it has this fork, and the maxillary teeth will fit into here, and the mandibular teeth will fit down over here. And if you look a little bit here, you can see that there are some numbers that will help you kind of calculate how much of protrusive range that they have. It'll look something kind of like this. You're gonna put the George gauge inside, and you're gonna ask the patient to move their jaw forward and backwards and read the numbers that it has on the top of it. And the number that we usually go for, according to the American Academy of Sleep Medicine, Dental Sleep Medicine, it can range from like 50% to 75%. It's kind of like a preference, and depending on the patient comfort and discomfort that day, you can go with the 70% if the patient is able to tolerate that advancement. So what you're going to do here is you're going to take the bite registration. You're going to use, we usually in our clinic use blue mousse. You can use any of the silicone materials. You can use additional silicone or condensation silicone. It's just way too expensive, and the blue mousse is just more convenient, and it sets really quick. We set the advancement in that, let's say 50 to 75% or 70%, and we apply the material and we make sure that the patient bite downs on it, and we have the indentation of the teeth. We need to make sure that we have at least one or two teeth in the front and one tooth in the front, same thing on the other side as well. And when we apply the material, it's not going to be only on the occlusal surface, it's also on the maxillary surface. Is also going to be on the mandibular surface as well. And that's what it's going to look like after you take it and you pour your impressions. And the appliance titration is attained by different means of like progressive mandibular advancement. So let's say, for instance, this appliance is called the Herbst appliance, and you can use these like screw advancement devices where you advance the appliance with. And if you look a little closer here, there's a plus and a minus. If you follow the plus sign, it'll advance the mandible forward. And if you go from the plus to the minus, it'll retreat it backwards. The same thing goes here for this appliance. You can see there is an arrow. If you follow the arrow, it'll protrude the mandible forward, and if you do the other way around, it's going to retreat it backwards. For this appliance, this is called a Panthera appliance. It's a digitally made appliance through CAD/CAM machines. These arms can be changed, and the shorter the arm, the more advanced the patient will be. So let's say this is a 27. If you want to protrude the mandible forward, you actually kind of like go the other way around. Compared with this, you're going to go with an arm that is the length of 27. And we have this also other design. These designs, I put them here because these are the ones that we usually use in our clinic. And for this one, it has that kind of like strap. And if you notice, it has a number. That 0 number, it means that this is where the advancement was when we sat. And if you want to protrude the mandible forward, you go with M1, M2, M3, and so on. So a study by Kito et al. Found that each 2 mm advancement was associated with a 20% improvement in oxygen desaturation index. And most studies have reported that patients require at least 50% or more than 50% of maximum protrusion to achieve the desired effects. So in the first month, what the dentist is going to do is you're going to, after you deliver the appliance, you're going to check for several things, things like tooth pain, tissue pain, joint pain, muscles, anything like that, and assess the efficacy of the appliance. The way that you can check for the assess for the efficacy is by asking the patient or their sleep partner if they stop snoring, how do they feel in the morning when they wake up, things of that sort. And if the appliance needs any adjustments, you can go with slow high-speed handpiece, low-speed handpiece, and you can adjust any areas that causes any discomfort for the patient. For around around next 3 to 5 months, the dentist is gonna probably continue on titrating the patient until they either reach their maximum capacity of protrusive range, or they feel that they are in a position where they don't feel there's any improvement in their sleep and they just feel fantastic. If you reach that point, then you're gonna send the patient back to the sleep physician, and that sleep physician is gonna perform another sleep study with the appliance on and see if the appliance actually corrected their apnea, their AHI or not. And the American Academy of Dental Sleep Medicine, they recommend that for the first year, the patient should be seen every 6 months. And after that, around once a year annually. So, and when they come to you, you need to check for things like occlusion, appliance wear, possible adverse effects, things of those sorts. And the average life span of a mandibular appliance, it is approximately around like 3 years. So when they come, you should check for things like cracks, discoloration, and lack of retention. And if you find any of those, you might want to replace these appliances. Here in the States, it depends on the insurance. They kind of like dictate when we are supposed to redo them or replace them if we needed to do that. So when we talk about the definition of success when it comes to obstructive sleep apnea, so if the patient went to that sleep physician and they had a sleep study and their AHI was less than 5, we consider that as a success. Sometimes they might not reach that level, but we can consider it as kind of like a partial success. And that if they have a reduction of more than 50% in their AHI. So let's say the patient came to you with a 20, with an AHI of 20, of 40, and after the treatment that they did, you managed to reduce it by around like 50%. That is 10 episodes an hour. It is still considered mild. It's not fully cured, but there might be like you might consider it as a like partial treatment success if they also include that their symptoms has improved. Their snoring has stopped. Their daytime sleepiness has gone away. The morning headaches that gone away. Things of that sort. So when we compare the effectiveness of the CPAP machines and the mandibular oral appliances, definitely CPAP machines are superior to the oral appliances in terms of reducing their OSA and their AHI numbers. The CPAPs, they work in around like 95% of the time, while the oral appliances, they only work around like 50% of the time. But this efficacy, it does not necessarily translate into better health outcomes. So there is a randomized controlled trial that compared CPAP and the oral appliances with varying baselines in OSA severity, and they looked into and they had actually like similar results when it comes to symptoms of like sleepiness, quality of life, and simulated driving performance. And also when it comes to cardiovascular outcomes, there were no differences between the two treatments with respect to the short-term effect of things like blood pressure and reducing the risk of mortality with severe OSA. And the reason why we think these two are kind of like close together is because the adherence on using these appliances. So we know that the oral appliance, the patients are more adherent and more compliant on using the oral appliances compared with the CPAP. There is a sleep apnea cardiovascular endpoint trial. They showed that the cardiovascular improvement with CPAP it's likely because of the low adherence. And in that study, they saw that there is an average of around like 3.5 hours of usage per night. And that might be a problem because if, let's say, the patient sleeps 8 hours and they only use it for half of that time, the other half of that time, the patients will be vulnerable to the apneic events. So it's very important that they stay adherent to that treatment. And in 20 to 50% of patients with OSA are unwilling or unable to comply with the CPAP, limiting the long-term effectiveness. That's why we believe the oral appliances are comparable with the CPAP because of their adherence and their compliance. So looking into combination therapy, we might think it might be reasonable if we add two treatments. These two will be they will combine for a better results, but there aren't a lot of results or many studies that look into it, unfortunately. I'm going to reference some of them here. So one study investigated the applicability of alternating between treatments of the CPAP and the oral appliance on a regular basis. And they found the availability of both treatments for the patients to use interchangeably could enhance the reduction of the symptoms. And there is another study that evaluated the combination of positional therapy in patients with supine-dependent OSA. So there are a subset of patients that when they take their sleep study, they will see that their apneic events that happens, they usually happen, or mostly they happen in a supine position. And in these patients, you can combine therapy with the oral appliance plus, or not necessarily only the oral appliance, but the oral appliance with something that they can use to help them stay away from that supine position. And this is kind of like an example of it. This is a product that you'll find it in Amazon. And if you just write down like sleep aid devices or something like that, you will find a different kind of design and things like that of that sort. There are some techniques where you can put it like a tennis ball, and you can sew it to the back of your pajamas, or there are some shirts that you can buy. It has like a pocket in the back, and you can put a pajama in it. There are some devices that you can put in the back, and the moment you go to that supine position, it'll kind of like vibrate, and it'll just notify the patient to stay away from that position, and hopefully they will sleep on their sides. There is another study that looked into the combination of oral appliance with the tongue reduction, the tongue retaining devices, and they saw that the combination could reduce the respiratory events compared to when they used the oral appliance without a tongue retention device. There is also a study that examined the combination of oral appliance with surgery, and there is a surgery called UPPP. It's uveopalato-pharyngoplasty, and they saw that if you combine both of them, this could help the patient or give them a cross-sectional area, keep the cross-sectional area of the stenosis of the site bigger. So that will help them hopefully having less apneic events. And there are some studies that looked into combining both, and I believe there are CPAP appliances that can actually accommodate having the oral appliances inside of the mouth. And they saw if you combine both, it helps reduce the required CPAP pressure and increase patient comfort, because the CPAP appliance and the BiPAP appliance, what they do is they push a lot of pressure inside of the lungs, and if it can be uncomfortable for some of the patients. So if you kind of combine both of them together, the oral appliance and the CPAP, it'll help reduce the amount of pressure, the air pressure that needs to be pushed into the lungs of the patient, making it more comfortable for them. So coming to the side effects of the mandibular oral appliances, there are some short-term side effects and there are some long-term side effects. So some of the most common short-term side effects are increased salivation, decreased dryness, and pain or discomfort in the teeth or gum, perception of an abnormal occlusion in the morning, muscle tenderness, and jaw stiffness. And these side effects usually are like mild and they are transient. Most of the patient, they accommodate to these side effects with time. Coming to the long-term side effects, you're going to notice here is just a lot of it has to do with the teeth. So retroclination of the maxillary incisors, proclination of the mandibular incisors, decrease in overjet and overbite, mesial tipping of the mandibular molars, distal tipping of the maxillary molars, increased mandibular arch length, downward rotation of the mandible, and posterior open bite. And that one is actually the one that we worry about kind of the most, because these long-term side effects, they can be irreversible. So it is a good idea that you mention these side effects to the patient before you actually continue or start the treatment, and tell them there's a possibility that this might happen to them. And we have here a study by Perez et al. In this study, I believe they looked into around like 160 patients retrospectively, and it was around like 400 by the baseline, the day of the baseline, and the last visit, it was around like 413 days later on. And you can see that around almost 20% of them, they developed posterior open bite. And actually out of these 20%, almost 30% of them, they were not aware of these bite changes. So what can we do to rectify that? There's this thing called the Morning Inclusive Guide, or some people call it air aligners. This is made out of a thermoplastic material. You put it in a hot water just for a few minutes, and then you make sure that the patient bites on it on their maximum intercuspation. And you fabricate this on the same day that you deliver the appliance to the patient. And you ask the patient to wear this, to use this device every day after they use their oral appliance in the morning, so they can put it between 5 to 10 minutes. Hopefully that might reduce the chances of developing this posterior open bite. It looks kind of something like that. And there are some different theories of why we actually develop this posterior open bite. We're still not sure what it is exactly. There are some people who speculate that it could be because of the patient. They are in this protruded position for almost 8 hours a night. There might be some some changes in the bone that like some bone deposition or something like that in the condyles that prevents the jaw from going backwards completely with time, and that's why they might develop this posterior open bite. And there are other talks that they say it could be because of the lateral tragoids. What happens is, so because of the lateral tragoid, it is kind of like contracted and it's in this the mandible is in this protruded position for 8 hours. What happens is stays in this kind of like contracted stage. And what happens, the muscle itself, it gets shortened a little bit. It's what we call a contracture, not a contraction, contracture of the muscle. That's why they believe these AML aligners, it helps kind of stretch the jaw and put it into this normal position. Hopefully, it'll stretch the muscles all the way in the morning. There are also some exercises that can be taught to the patients to be used in the morning if they're not compliant with using the AML aligner, or they still developed the posterior open bite. You might try one of these exercises where you ask them kind of like to push their jaw, to move their jaw forward and backwards all the way to make sure that it is stretched. They can also use what they call a thinker's pose, is when they are pushing their jaw kind of like that to make sure that they stretch the muscle all the way backwards. So although these side effects might seem like substantial, but at the end of the day, they are outweighed by the benefits you gain from the oral appliances, because just as I mentioned earlier, obstructive sleep apnea, it is a life-threatening condition. And I don't think I can think of anyone who would probably say, okay, I'm okay with dying compared with having side effects of this appliance. But if the patient should not discontinue the oral appliance unless they have another treatment modality that they're gonna adhere to. So we just make sure that you reinforce that to your patient and make sure that they have other alternatives that they can use if they're not using the oral appliances. So kind of like the takeaway message, take home message from this presentation today is, even though there are different treatment modalities available for the management of OSA, CPAP and the oral appliances are the most commonly used disease-specific therapies. And CPAP has definitely an advantage of greater efficacy, but when it comes to the effectiveness, the oral appliances, they are more effective, and because of the patient's adherence and acceptance to that appliance. And for a lot of them, it's just more convenient. The CPAP machines, it's a little difficult if they want to travel with it, and they're a little bit noisy, things like that. But the oral appliances are more easy to carry with you, and it doesn't have that noise problem. And there is no single ideal mandibular oral appliance design, but what we say is kind of like the closest thing to an ideal is definitely a custom-made one that is comfortable for the patient, and it produces the mandible, so it's not fixed. It needs to be titratable and keeps the vertical opening to a minimum, and can be adjusted to achieve the optimum efficacy while being comfortable and well tolerated by the patients. Thank you everyone for listening. And if you have any questions for me, I would gladly answer any of them. And if you want to do them later on, this is my email address. You can contact me at any moment. I'll be happy to help you out.
All right. Thank you so much, Dr. Eisa, for that wonderful presentation.
Okay.
This is an area, sleep medicine is an area that is upcoming, and we have solutions for our patients. People suffer from this. If you put a questionnaire on all your cases in terms of having, you will be surprised that most of your patients have these, and you'll be missing an opportunity here if you do not, learn about it and see how you can offer them some help. I do have a question here. He said, thank you for your presentation. Please, during titration, do you take multiple impression or just one?
No, it's just one impression that should be taken at the beginning. And once you have the appliance fabricated, you don't need to take another impression. It is an impression of the teeth. And what happens is these appliances can be titrated forward. So you don't need another device to kind of like change it between these titrations. The appliance itself can be titrated forwards that way.
All right. Thank you so much. Dr. Montin, you're still there. I don't know. I'm not exactly sure can you see the Q&A?
Yes.
There's one that says, what was the one
from Dr. Schur?
Yes.
So what was one thing that you found most valuable to learn through this process? I don't know which part of the process.
Sure what she was referring to. I don't know if it's the process of getting into school or the process of, I'm not exactly sure.
Yeah, which part? I'm looking at the time. I think it was right when I had just finished speaking. So I'm assuming it was more about the process of, maybe that Chrome case or anything, but I would say more, and this would be for any case, do your homework ahead of time. Make sure that you treatment plan everything correctly, because that's the way that you're going to have the surgery go as smoothly as you possibly can. Obviously, you don't know how the bone's going to go and all of that, but, and definitely explain things to the patient and don't sugarcoat anything, because it's not, the patients are expecting for you to do the best that you can. So.
Okay. I have another question for me that came in through a text. They said the case you talked about, the number 30, that you extraction and immediate placement of an implant.
Yes.
So the questions here is that that tooth had like you said the tooth had like a large radiolucency, from.
Yep.
So immediate placement in an area that had that kind of infection. What he wasn't exactly sure.
Yeah, I actually questioned that as well, when we were treatment planning it, of can we place an immediate implant, right, with all of that. But, we had her on antibiotics, we cleaned it very, very well. And, after we examined, what was left after the tooth was extracted, it was fine for us to place that and get that torque, and, knock on wood, haven't had any issues or anything. And it's been 6 months, or I'm sorry, it's been 8 months now.
Okay.
So, yeah.
Anyway, so that was a question that came in through what somebody sent me a text about that case.
I thought the same way. Don't worry.
It's been a wonderful time. Tomorrow we're going to have, guys, I need you to send we need to be here tomorrow. Tomorrow is going to be, fantastic. Dr. Ali Reza is going to be speaking on dental ceramics, a clinical perspective on material selection. Who doesn't need that? In today's world where, different materials are out there, I think is going to be quite an explosive presentation. And we're going to have Dr. Fernanda. Dr. Fernanda, are you on?
Yeah.
All right, we're going to see Dr. Fernanda's face tomorrow, because she'll be speaking on sleep bruxism, giving an overview, and it promises to be a wonderful presentation. On the 29th, we're going to have Dr. Alfonso Pinheiro. If you miss anyone, please don't miss Dr. Alfonso. He's a very well-known speaker, and he's very, very vast and very wise guy, and he's going to be there. I'm just going to stand by his side. I'm going to share a little bit on evaluating restorative space for implant. Every person that has presented in these webinars keep talking about restorative space. Dr. Montin, you mentioned something about that case, right? There was a case where immediately you put the slide. I said, okay, I should have that slide. I should have that photograph of that premolar and where there was not much of restorative space. What did you say you did?
So place the implant 2 millimeters subcrestal.
Okay. Yeah. So
Yeah.
that gives you buying some, so that at some point you got to figure a way out. You got to find a, because if you don't have the space, there may be sometimes some type of implant constructs will not work. But if you have, that was a very wise one there, going deeper so that you can at least buy some time, some length on there.
Yeah.
In other cases, what would you do if it was in the anterior? What other options would one have? Especially if the implant had already been placed.
Oh, if the implant's already placed, then sometimes you just have to sink that implant and say sorry. Or obviously there's the option of removing that implant and starting from scratch. But wow, in the anterior with that implant already placed, I don't know, I'd have to kind of examine everything else that's around there. I couldn't give a straightforward answer.
Dr. Montina, I will need you to come back on the 29th because we are going to talk about it. The implant is already placed. We don't have space. But I think that prior to getting things done, we need an interdisciplinary approach, because sometimes you need ortho to intrude some teeth. You will need to do some plasty on some teeth. If it's already placed and there's nothing you can do, and like you said, sometimes you might just have to take the implant out, because it is, before we go into, restoring, let us treatment plan and look at, you said it a while ago, in terms of we need to do our homework before we start treatment. Let me see, is there any other, okay, who is going to moderate? Oh, I know what Dr. Montina is going to be here. So if she has time, Dr. Montina, I think you are already a part of the dental webinar series family. There's some people that come in, and in a short time, I can tell that they're going, I can call on them for help. But I think, it's going to be wonderful. Also, we have, I need to show you this coming up. We have Wax Up on the 30th. We have Wax Up. It's fun. We did it in dental school. And as a resident, you need to be able to understand, how to wax up teeth. Dental anatomy is key. And we have a dentist from Spain, Alejandro Coelho, is going to be with us on the 30th. Talk about wax ups. And we also have trigeminal neuropathies following dental procedures from Dr. Hafsa Effendi. She's here in Michigan, and it's going to be really. And on the 6th of September is already filling up. We're going to have some wonderful presenters for September, but we do have endo. People have been asking me, they want to see other things other than implants. So we're going to speak a little bit on endodontics and just treatment. Dr. Rodillo is going to be speaking on relating pulp biology to a typical endo case. And these are things that we already, so restorative dentists out there, log on, it's going to be on Sunday. The schedule for September, I'm going to bring it out later during the week, but it promises we are going to learn something. And these things are available on YouTube. You can go there. These videos are going to be uploaded. It's a learning time. And I'm going to be introducing an app very soon, the Dental Webinar Series app, so that you can have it right in front of you. You can download those YouTube videos on the app, and you can learn on the go. Learning is here, and we're not going back. Thank you so much, guys, for coming today. Looking forward to having you tomorrow for our continuing series. Thank you so much, Dr. Eisa and Dr. Monte.
Thank you.
Thank you so much again. Take care, everyone.
Okay, bye-bye.
Great job.
You did fantastic. It was a very good presentation, and looking forward to having. I need you to come back to talk on your DDS Ignite. I think a lot of people are interested, in learning about it. So I think it will be a great resource for everyone, because everybody wants to. People want to progress in their lives. People want, and you have just having those tools will be key.
Yeah, no, I'll talk to my mentor as well, because he's the in charge of the Ignite DDS part of it, and so I'll talk to him as well and bring it up to him and see what we can figure out.
Okay, All right, no problem. So I'll reach out to you off camera and we'll talk more. Thank you so much and have
Sounds good. Bye-bye.
Healing Hands Health Society presents Dental Webinar Series. We have planned a series dental webinars to keep you abreast of current practice. This series on prosthodontics will be via Zoom, Facebook Live. Presenters are drawn from dental schools in the USA, private practitioners from around the world. To register for future webinars, visit www.hhands.org/dental-training. For future inquiries, contact Facilitator